Great. Good morning, everyone. Welcome to our Friday High Rounds. We're very lucky to have Dr. Greg Aarons today with two more implementation science experts, Dr. Ezeanolue, which I will ask him to pronounce that again for me so that I can learn how to say it properly, and Dr. Eneh. So Greg will be giving the first talk, and then we'll hear from the other two speakers. So I'll briefly introduce them. Dr. Greg Aarons is a clinical and organizational psychologist specializing in implementation science for more than 25 years. He has more than 340 peer-reviewed publications with more than 49,000 citations, and is on the top 1% of Clarivate most influential researchers in social sciences. He co-developed the widely used exploration, preparation, implementation, sustainment EPIS framework, and the LOCI LOCI implementation strategy and implementation science measures assessing leadership, organizational context, sustainment, and attitudes towards evidence-based practices. He develops and tests implementation strategies to improve implementation of behavioral health and cancer control evidence-based practices in the US, Africa, Mexico, Norway, and Australia. And we're very happy to have him today with us. Next, we will hear from Professor Echezona Ezeanolue, who received his medical training both in Nigeria and the United States, and subsequently focused his career on the use of implementation science and practice to enhance the effectiveness and quality of health services. For over a decade, he served as the director of the HRSA-funded Nevada Comprehensive Maternal Child HIV program in Vegas, and he has broad experience in implementation science and clinical effectiveness research, and has been PI, MPI, or co-investigator on over 25 peer-reviewed funded projects, including the NIH-funded baby shower trial that recruited 6,000 women across 40 sites, ISTAR trial that recruited 10,000 women, and 7,000 male partners across 80 sites, and the round point of delivery prenatal test results through mHealth to improve birth outcome, which enrolled participants across 100 sites in Nigeria. He has held various national positions in the US, including Robert Wood Johnson Foundation Health Policy Fellow, the Disparity Advisory Panel Patient-Centered Outcome Research Institute member, and is a member of various institutions. He briefly returned to Nigeria to lead the National Primary Healthcare Development Agency, the largest health infrastructure in sub-Saharan Africa, and in 2018 he accepted a position as director and professor of the Ivan Research Institute at the University of Nigeria. He continued his leadership in the Nigeria Implementation Science Alliance, which he founded in 2015 in collaboration with the NIH Fogarty International Center. He led the development of the NISA Model Innovation and Research Centers and created the first practice-based research network in Nigeria with 36 sites across the 6 geographical nations of Nigeria. This network provides care to a population of over 5 million, including comprehensive care to over 65,000 women of childbearing age living with HIV and over 60,000 annual deliveries as a research coordinating center. So we're very excited to hear from him, and we're also going to be hearing from Dr. Stanley Eneh, who is a Nigerian research scientist with expertise spanning epidemiology, infectious diseases, and implementation science. He holds a Master of Public Health and a Master of Science in Epidemiology. And Stanley has led and managed national projects funded by the National Institute of Health, World Health Organization, American Association for Cancer Research, Canadian Institutes of Health Research, USAID, among others. And Stanley has authored and co-authored over 30 publications and serves as a reviewer and editorial board member for several health and medical high-impact journals. His current research interests include genomic epidemiology and mathematical modeling. So we've got a lot to look forward today, and without further ado, I'll leave it to you, Dr. Aarons.
Okay, thank you, Anik, and just a pleasure for us to be here to talk about some of our work in Nigeria and globally. So our talk, Building Bridges, Implementation Science and Capacity Building in HIV and Cancer Control in Nigeria. really kind of summarizes the work that we do. And it's both research and capacity building. So we had the welcome and introduction. Going to talk briefly about some implementation terms and framework. Our large-scale UO1 study that's part of a consortium of 16 funded UO1 studies focused on implementation science and cancer control for women living with HIV in actually many countries in sub-Saharan Africa and also in South America. And then we'll talk about capacity building and all the great work that's being done by Dr. Ezeanolue and Stanley and colleagues. And really have an invitation for new collaborations and participation. And we have no conflicts of interest to disclose. So just briefly, for those not familiar with implementation research as defined by the NIH and others is the scientific study of the use of strategies to adopt and integrate evidence-based health interventions into clinical and community settings to improve organizational, individual outcomes and benefit population health. And this has been an initiative that started really with the National Cancer Institute and the National Institute of Mental Health, who then partnered, and now I think it's 17 of the NIH institutes have signed on to those program announcements. And I'm not going to go into the key terms here, but there are kind of specific things that we talk about in terms of implementation strategies are the things that we use to get the evidence-based thing we want to implement into practice. And when we talk about determinants, that's really the barriers and facilitators to implementation that we address through strategies. In the introduction, you mentioned the exploration, preparation, implementation, sustainment framework. This is one of the more commonly used frameworks that really helps us think through what's happening kind of in the outer context of policy that can impact implementation. What do we need to address in the inner context of organizations that provide care? That could be hospitals, hospital systems, community-based clinics, NGOs, community-based organizations, schools, you name it. It's like what's happening where we do the practice. And then what we talk about is innovation factors, about the evidence-based interventions or the things we're trying to implement, the characteristics of those, how implementable, sustainable, do they meet the needs of clinicians, of patients, and are they supported by health systems and insurers? And then this idea of bridging factors that links all of these together. So for example, if there's a policy that's made, how does that translate into the implementation of what's indicated in the policy into practice? So for example, Irene Su here at UCSD is OBGYN oncologist who looks at legislation around fertility preservation and how that translates through health insurers to bring services to clinics and providers. The other piece of the EPIS framework is the phases. And there are specific activities that take place in each of the phases. For example, exploration phase, we're thinking about population or clinical health needs and how we can address those barriers and facilitators through developing implementation strategies. In preparation, we're really moving to thinking, okay, we've decided on what we want to implement. How do we go about that? Then we move to implementation phase where we're actually implementing and seeing what we didn't recognize in the prior two phases as the rubber meets the road, as they say. And then we sometimes have to adapt and really pivot to address emergent issues in the implementation process. And then in the sustainment phase, we're really thinking about how do we maintain evidence-based care with fidelity as we go forward. And I like to say we should be beginning in the exploration phase, thinking about sustainment and planning for sustainment, because we don't want interventions that are implemented to go away or to drift from their core elements, core practices. So that's the very brief implementation science overview here. And I do want to mention here at UCSD, we have the ACTRI Dissemination Implementation Science Center for anyone interested. We do offer free consultations. We love to talk to people about ideas for implementation and help support those activities here at UCSD and beyond. So I want to just briefly give an introduction to our U01 grant, and this is Accelerating Cervical Cancer Elimination through Integration of Screen and Treat Services. And this was funded on the NCI program announcement, or RFAs, that I mentioned, for implementation science in cancer control for women living with HIV. And this was funded in the first cohort of these, which was 8 grants, 4 in Nigeria, the rest in Sub-Saharan Africa. And then most recently, in the last year and a half, another 8 grants were funded. These are continuing despite the changes around funding policy for foreign sites. So we have worked with the NIH, and our program officers have worked through NCI and through NIH to come up with a mechanism so that we could continue these projects to their fruition. So we're very grateful for that. I am multiple PI with Dr. Ezeanolue, and this is part of a long-term collaboration that we have had in before the beginning of the Nigeria Implementation Science Alliance in 2015 through work that I was doing, training implementation science for the Fogarty International Centers for a number of their initiatives in Sub-Saharan Africa, and where I first met Dr. Ezeanolue, and we hit it off and have been collaborating ever since. A very positive collaboration. So our co-investigators on the ACCESS study include physicians, sociologists, others in areas of HIV, prevention and treatment, cancer control, qualitative and quantitative methods, including Dr. Lin Wu, who's part of the ACTRI here at UCSD and in the School of Public Health, and the rest who've become close colleagues through the process. And we have a number of collaborating organizations throughout Sub-Saharan Africa and throughout Nigeria. And just for context, Nigeria has the largest population of any country in Sub-Saharan Africa. And when we're working across different areas of the country, there are different geopolitical regions that some may be Catholic, Christian, Muslim. So there's adaptations and adjustments we need to make to do our work in different parts of the region. And for this study, we have 12 sites, and this is when we were training our site coordinators in Enugu, Nigeria, a few years back when we were just starting the project. And we do have a couple of publications out, one talking about implementation mapping that we did to identify strategies to address barriers and facilitators that were identified through a collaborative process with different actors, different collaborators across Nigeria. And then our study protocol paper was published in the Journal of Implementation Science, where I'm also the co-editor-in-chief, but it is the flagship journal for our field. And with that, I am going to turn it over to Stanley Eneh. And Stanley, do you want me to advance slides, or do you want to share your screen?
Okay, thank you, Prof. I can share from here.
Okay, so I am going to stop share and turn it over to you. There we go.
Okay, thank you.
And for everyone on the call, Stanley is in Nigeria, so we've got a 8 or 9 hour time difference.
Okay, thank you. Can you see my screens?
Yes, we could see. Go ahead.
Okay, thank you, Prof, for giving us a full overview of what the ACCESS study and our collaboration so far. So I'll give us a full overview of what ACCESS study is and all the programs, and also we are open for a lot of collaboration. So using implementation strategies, scientists we actually discovered here in Nigeria, there's a large burden of HIV and cervical cancer, which actually requires a lot of implementation strategies, whereby we want to actually cover cervical cancer streets, especially here in a low-income country like Nigeria. And in our study, ACCESS study, we try to integrate different strategies to implement to actually improve cervical cancer among women living with HIV and AIDS. So, because of the essential of trying to integrate a lot of strategies to ensure that women living with HIV and can anyone hear me? Yeah. Okay. So to ensure there is a proper coverage of uptake of cervical cancer among these vulnerable populations. So we have actually tailored a lot of implementation strategies that we are currently testing across our study sites. So in our study, I have a general overview whereby we are trying to compare effectiveness of two sets of strategies, which I'm going to give you more details while we go down to this slide. So the effects of this strategy, we have a core condition which have a 5 component of strategies, and also at the same time we have an additional strategies that we had, which make it go core plus, making a total of 7 strategies across that we are actually using to implement ACCESS UO1. So at the same time, another objective, which is trying to enhance the integration of the cervical cancer screening into existing program in Nigeria. So our specific aim is this is a 5 years grant, where it's a 5 years grant whereby we're currently in year 4 of the study. When we started this study initially, what we do was we try to refine the strategies whereby we involve these key stakeholders who have been given this particular intervention across this vulnerable population. We comes together to provide a strategy that was actually refined by the investigators, which was what Professor Aarons shared as part of the publication we have done so far. So between year 2 and year 4 of the study, we are currently in year 4 of the study, we are actually determining to compare the effectiveness of each of these 7 strategies, which I'm going to give a full explanation while we go down. So at the same time, we aim to do as a sustainment using EPIS framework. We're currently in implementation phase of EPIS framework. So the 5th year of the project, we are going to try to assess the sustainment to know how to assess the 7 strategies that we have really deployed across the 12 sites. So trying to give a full overview of the framework we used. Our study is being guided by 2 frameworks, which we used: EPIS and RE-AIM. The AIM is an evaluation framework which we use in evaluating the activities that we have done so far. So trying to give more details, this during the exploration period, which was what we actually did in year 1 of the study. Then after we have stratified the strategies we wanted to use to ensure that we implement to achieve all our aims, we went for preparation phase. APIS framework has like 5 stages, whereby we try to tailor the adaptations and also to track adaptation of what has happened so far in our study. We went ahead and also trying to deploy these 7 strategies, which is divided into 2. 5 strategies plus extra 2 strategies across the site. And at the same time, we're actually assessing the outcomes of the study using the RE-AIM framework, and which is currently in year 4. So in year 5 of the study, we are going to do the sustainment of the study, whereby we're going to use PRESS, that's a provider reporting sustainment scales, to evaluate, to know if this particular the strategies we have deployed so far are effective, or if they have been sustained across the study sites. So to give you overview of one of our core key strategies that we use here in Nigeria in implementing our studies is that our studies are being done across the sociopolitical zones in Nigeria, which is one of the main strategies that researchers over here in Nigeria do use. Our study is quite different from what they do over in Africa, whereby we try to cover across the sociopolitical zone to have a pure representative of what study is all about here in Nigeria. So I'll give you a free overview of which is our main sites, and all of them are secondary care facilities. And if you can see what we have here, it was actually represented across the zones. And these sites are on in part of NISA and innovative research centers across the 12 Nigerian zones, whereby this is at the site where we implement these studies. And apart from the access to the other studies that are also going on in this site as well. So this is the strategy we've actually been using to have a well-represented data and information that when it comes to research and implementation science. So to more detail about what we do in a core and core plus, there's the strategies that were heavily refined in year 1 of the study. Like I initially stated, is 7 strategies, 5 core studies and additional 2 strategies. In each of these strategies, when looking at the way the study is being designed, we have the first, second to 12, and the first strategies in our study is what we call providing ongoing consultation, whereby we actually have to engage the clinicians across the 12 sites, where we use Aviva app with the support of a gynecologist at the back end, who actually helps to support the clinicians to making decisions whenever they are screening women in cervical cancer. So, and in this study, we tried it's been done real time, and being delivered that virtually, so also to support them across site. We also have another strategy we will call strategy 2, whereby we hold educational meetings across the 12 sites, which has been done monthly, and it's been done by the clinical teams. And at the same time, we also have a 12 XRCs, 12 strategy coordinators, who helps in implementing and also ensuring that the strategies are being well deployed across the 12 sites. We'll also try to use another strategies, which is strengthening the ties with stakeholders, where this is what we do quarterly, whereby we engage the Ministry of Health, we engage implementing partners, we engage funders, clinicians, site doctors, and directors. This is where we actually provide the challenges we have had so far trying to implement the studies, and at the same time, we gathered solutions from their insights, and we also document and also provide sessional action options, especially during the time when we're having issue with the kind of funding. So at the same time, we also have another strategies, which is strengthening the referral system. In our study, we try to refer patients across site whenever we identified individuals who have screened but needed some treatment. So the patient will be transferred to a site whereby a gynecologist can actually take care of the person, and it's being done by a trained referral coordinators across the 12 sites. Apart from that, we also have a network across the 12 sites whereby these patients are being referred, and has a lot of SOP that actually guide all the strategies that we use implementing the access study here in Nigeria. The fifth strategy is trying to prepare patients to be active participants. In actually trying to engage all our patients to be active in a study, we have actually deployed using flyers, the strategic flyer that we design, which in form of a poster and in form of a flyer that we do share across site, and it's been given to patients whenever they come to the facility. And I think that we place this strategy, we place these flyers across the strategic regions in the hospitals, whereby we're also trying to monitor the activities and see the effectiveness of this flyers across the 12 sites, because we are going to use that to make a decision at the end of the day. So the last 2 enhanced additional strategies is HPI, Committee Headed Initiative, whereby it's been done quarterly, and it's a group whereby we gather the women living with HIV, and we provide educational lessons and for them, whereby they discuss the challenges they have, especially in this kind of vulnerable population. We actually use this strategy in order to ensure that we reduce stigma among them, so they can discuss this issue, because this activity is being done between them and cervical cancer screening nurse across sites. And this is being done quarterly. And the last strategy is what we use as engaging patients using mHealth platform, where we use mHealth, where we try to ensure that we engage patients by giving them a reminder. It is time for you to go and retreat and take your treatment, and at the same time to keep them in touch in order to ensure that they are having this cervical cancer screening uptake across the 12 sites. So currently in the year 4 of the study, across the 12 sites, we've been able to enroll about 4,603 patients across the 12 sites, which in this study we have, like Professor Ezeanolue is going to speak on, we have generated a whole lot of manuscript ideas that are actually open for collaboration. So trying to implement this study, we have actually had a lot of challenges that we document, and at the same time, we also at the same time trying to keep in touch to ensure that we document the adaptation, and at the same time to ensure that we are being guided by the framework that we're using in this study. We've actually had a counter whereby there's a reshuffling of staff, which we cannot control across the 12 sites, but we monitor the implementation strategy to see how that can be resolved. And at the same time, we have actually had a challenges whereby there's a cervical cancer screening interval when it is what been discovered across sites. What we do when we have this kind of issues, because according to World Health Guideline, it is stated that you are meant to screen a woman who's living with HIV for 2 to 3 years because of their vulnerable nature. But when we discover that, we come through engagement and trying to do de-implementation to ensure that this particular gaps have been taken correction. You all can actually believe that the implementation is one of the hardest parts when it comes to implementation science. So we try as much as possible to implement to ensure that all the implementers, the clinicians are actually adhering to the World Health and PEPFAR guidelines to ensure that we save our mothers and women, our grandmothers safe when it comes to giving them improper treatment. At the same time, we've had a lot of issues that had to do with shortage of the supplies, turnover staff, and at the same time, one of the hardest issues we have so far trying to implement access study in Nigeria is stop work order from the United States. That is the order from Donald Trump, which was one of the most greatest challenges we have ever had, which actually pushed around the whole world, and at the same time impacted in some of the studies that people do that are in Nigeria. But as we are actually conducting implementation strategy, we are testing the effectiveness of strategies. We're actually monitoring the challenges to see how we can mitigate these issues. Okay, thank you. I don't know if you have any questions on this. Thank you.
Yeah, I think we're going to turn it over to Dr. Ezeanolue at this point. Dr. Ezeanolue, do you want to share your screen?
Yeah, no, Stanley, you can keep on sharing the screen. I'll just ask for next. If you can help with that, that would be helpful.
Okay, Prof. Thank you for that.
So I'm going to try in the short time so that we can have a time for discussion. So next slide, to talk a little bit about of the opportunities and one of the things that we're looking at achieving from there. Next slide. I'm going to talk a little bit about one of our 4 centers that actually focus on training, capacity building, and collaborations. And this is just to talk that in the beginning, I was just a clinician, and that's one of the things I love to do. I'm a pediatrician by training and an infectious disease physician. So I still practice, I still see patients. I'm actually in the US right now seeing patients. So I still see patients a quarter, 25% of my time in clinical care. Next slide. But one of the things Greg we talked about was when we first met, me and Greg met almost like more than a decade ago. I can't even believe it that it's been that long. But one of the things was that we had a lot of challenges in Nigeria at the time because most of the programs in Nigeria were being headed by the US institution. And at the time, there was a transition that was going on where the US institutions were being asked to transition all the programs to country ownership. And that was a very huge vacuum. You can imagine at a time when the only way you can present your work you have done in Nigeria is actually come to CUGH in the US to present the work you've done in Nigeria. So most people in Nigeria actually have to travel to these conferences outside of Nigeria to learn about the work that's been done in Nigeria. So that was one of the objectives of the Nigerian Implementation Science Alliance. We didn't think it was right. when people are going to be hearing about the study done on them in a different place. We felt like there should be a local dissemination, there should be a regional dissemination, there should be a global dissemination, and that's how you do that. And just publishing research, we have known, doesn't really affect a lot of things. It takes 17 years to get those things into practice. So the only way you really can get that faster is to involve them at that particular time. So one of the goals of the Nigerian Implementation Science Alliance was to create a dissemination platform that brings together policymakers, implementing partners, researchers, and funding agency. And that's what we did when we started Nigeria. I think Greg was at that first meeting. The second thing that we wanted to do was to enhance the capacity in implementation science. Nigeria have a well-educated workforce. In one of the things you talk about Nigeria as limited resource area is not in terms of its youthfulness. Nigeria has one of the largest youth population in the world. The next thing that we wanted to do was to build the research infrastructure to conduct clinical trials and implementation research. So I'm going to talk a little bit on each of these three things, what we have been able to do for you to see an opportunity of where you could engage. Next slide. And this next slide is just to show you since 2015, when we started Nigerian Implementation Science Alliance, in terms of the topic area that has been there, and in terms of attendance, and in terms of accepted abstract. You will see as we move forward, you see that increase from the 22 abstract that were accepted to 140 last year. And that is giving you that we think we have achieved what we wanted to do. We have gotten from that number, from 150 to triple that number now of attendance. And one of the things we want to be able to do is to create that forum where people actually be able to present their work, but also bring in all the collaborators that work in Nigeria. So Greg has been to more than, I would say 70% of these, if not all of them, that are doing this conference, which is one of the things that our relationship has been very strong, because he actually goes to the site. He has been to a lot of the sites where we do these studies. He has met a lot of the people who have worked on these studies. He has met a lot of the policymakers that has been there. So he's actually coming to Nigeria, has helped so much in building this forum, because people actually come there to meet a lot of those things. Stanley, can you wait until I ask for slide, please? So thank you. So this is just for you when you want to be able to look at those ideas. Next slide. So this is our platform for capacity development, and this is we have had some people actually attend from UC San Diego, which is something that we would like to see more about. So this is one area of engagement that we would like. One of them is what we have. We call it a weekly research in progress. So it's a 2 to 3 hours on Mondays, and we put that period of time for anyone that is thinking of an idea. Do you have a research idea? Whether you wanted to design it and you're designing it in areas that may look like Nigeria, and you wanted input from people who actually work in those areas to be able to give you input in your designs, in your on how you're working at it. But it's one thing to be able to sit down in the US and design a study in these countries. It's one thing to get an input from people who actually carry out research in those people to give you input as you design those studies. So this has been one of the most important things that people have liked about our training capacity, is where they can actually go and get an input from a lot of people who work in this area and who also have got grant in this area. We have monthly webinars, and that is another area of engagement. So it's another area we invite people to speak on areas where they have grants and support and research focus on. So if your interest is in colon cancer, you're able to come here, talk about the work you do, and talk about opportunity. If your interest is in prostate cancer, breast cancer, or if you're not in the cancer and you are in a different area and you're looking at hypertension, these are areas, or you're looking at mental health, these are areas that we also have fundings in, and we have an infrastructure to be able to conduct research. The NISA Research Week is one of our most important research week. One of the things we do is we bring in people who, like Greg, who developed the APIS framework, for example, and then we match them with people who have used the APIS framework in Africa. So these are people who have said, I like the APIS framework, I use the match study, but we also want to hear about what adaptations they needed to make in order to use the APIS framework, which was developed essentially by all people from high-income countries. I don't think that's one of the things I'm bugging Greg, that next time we have to make some adjustment and get some input from where these frameworks are used. Is the same problem with ERIC strategies. All of them were designed by people from the high-income countries. And some of them, of course, have had experience like Greg of working in resource-limited settings. But it would be nice to look at those importance of culture, context, and how they affect the use of these frameworks. That's important thing. The research administration training is something that is phenomenal. It was one of our best relationship with the UC San Diego because when I went back to Nigeria, one of the first things I wanted to do was, before we start to apply for a grant, to actually build an office of research and sponsor project administration, which we have the best one in Nigeria, I could say. We have full-time staff in all aspects of it: pre-award, post-awards, policy, legals, and all the things that are finance that is needed for you to run a good administration. So for 3 years, we got funded by Fogarty to develop this between UC San Diego and the University of Nigeria and the Urban Research Institute. And that's one of the things we have now moved forward to be able to do that training for the entire country and region. The annual conference is what I've shown you before. Something new that is interesting that we're going to be starting is that starting in April, we are going to start our PhD program in implementation science. It will be one of only 3 PhD programs in Africa. One of the challenges Africa has had is that, of course, people used to travel to the US, be able to have training in the US and return back to Nigeria, and some of them will stay here. One of the challenges we had, a lot of the people who travel to the US never return, which is true. And then, so even though you're training more people, you still lack the capacity. And a lot of the places don't have the capacity to train in Nigeria. Like I said, there are only 3 PhD programs in Africa. Now, what we're trying to do is actually to have one that has the standard. But to do that, you have to build all this infrastructure we have been building for the last 10 years, to have a conference, to have partners, to have where they can do that. Next slide. I want to show you a little bit about that, about all the other things we try to do in preparing for that PhD program was actually to start a training for scholars. So in 2023, we started with 12 scholars. We actually, in 2022, we started, Greg and I, when we were writing the essay study, the first thing we did was actually to assemble both early stage investigators and mid stage investigators and established investigators who are professors. But one of the things we wanted is to be able to build a lot of them who have not done research to become, so that was our first training cohort in 2022. Those training cohorts are what you now see as mentors in the last 3 years. So in 2023, we have 12 new scholars, and you can see where you have the mentors. These were all the mentees that were on that in the first grant that we wrote to be able to do that. And that's the pathway we wanted to be able to build. In 2024, we have 17. In 2025, we have 16. And we have one single criteria for all these scholars. We want them to submit a competitive grant. The reason we use that as an outcome is that we believe that by the time you can submit a grant, all the skills that is needed, you will know how to synthesize the literature, review the literature, synthesize the literature to find the gaps. You know how to develop an intervention. You know how to put a team together. You know how to write an analysis plan. So all the skill set that you need are all embedded in writing and submitting a competitive grant. One of the things that was remarkable that we've seen is that almost half of the people in 2025 have already submitted grants, which is a very interesting increase in what we have seen before. We have looked to see one of the things that we have changed and all the things that we have made changes that led to that increase. And that's something that we're looking to expand in the next cohort that will be 2026. This is a place, all the faculty, all the mentors are volunteer, but one of the things it offers you an opportunity is that this is an area you can actually come listen to these scholars, like when they present, and see people who might be in areas where you have an interest, who actually may have a concept that is interesting to you and who you can collaborate with. So I think this is a very good opportunity for you to say, I want to see what they're doing. I want to see what all these scholars have been doing. And we can give you a list of all of the projects they're doing to see if any of those is of interest to you, and then connect you with the scholars. That's one of the hope that we have of building a stronger academic relations between the two institutions. Next slide. And I'm not going to talk about this a lot because we talked about it. This is the G11. This is the main grant that started our relationship, because if you don't have a good grant management office in any institution in resource limited setting, you don't want to do research there, because it kind of creates an environment where you're not sure of how that grant is managed. So this was the smallest grant that we got. I remember Greg, even all of us saying, why do we put our time on this grant? Because it was small. It was basically $30,000 for the things that we have to do there. But the truth is that this is the biggest grant that we got. And this was the biggest impact that UC San Diego have had in Nigeria was building this infrastructure. Now there are about 36 medical schools in Nigeria. Only 4 institutions have gotten this G11. But now our project have now grown to where we are working with Encura and other global grant administrators to actually build an infrastructure they call CARA, the Committee of Research Administrators and African Research Administrators. And then we are actually going to do a South-to-South training so that all of those medical schools, all of those institutions that do not have those grant office, that we can help them set those up and be able to grow that. But this is a very huge, important grant for us in terms of its impact. Next slide, please. And I'm not going to go through this, but this is all the stage that we have gone through the G11. Next slide. This actually was recognized. They asked us to present this at the Fogarty Council meeting. And after we presented it there, everybody there was really very happy. The first question they asked, he said, we have been training as a U.S. institution, at a U.S. NIH. We have been using this infrastructure to train institutions in Africa. Have any of them that we trained any other person? And the other answer was no. So, and that was one of the things we actually all planned to do before, things happened in November last year. So, but things change. We're hoping that when things are better, that we can actually be able to, we have the infrastructure now to actually do the trainer from a South-to-South training, which would be a remarkable thing to see that a U.S. institution can train an institution in Africa that grows to become a training center in Africa. And that's something that we want to see. I think it will be one of the things that UC San Diego can look back and say, this is one of the impact that we have. And it wasn't about the grants and just about this, but actually having a real impact in moving things forward. Next slide. This is the PhD program that I talked about. One of the things that is going to be here is going to be a certificate program, a master's program, and a PhD program. We are trying to build a collaboration. We want to be able to see people who are interested that can speak at those to our scholars on there. But one thing that is interesting that makes a difference is the last bullet point you see in each of them, which is the embedment. So you see all the partners we have grown the Nigerian Implementation Science Alliance. The last year of that PhD, we want them to actually embed in those partners and be the resident implementation scientists so that they actually learn and work with them, the implementing partners, and they'll be able to, that's how they rise. So it's not just about writing the thesis, but actually having the on-the-ground experience. We're also offering that to people who trained in the US, but who don't have that opportunity to have an embedment, but finish that PhD, that when they come back, they actually can still participate in that embedment program. Next slide. This is the practice-based research network, which is this, one of the things we wanted to do. It is a growing part, and this can see that part of it on the global collaboration, and you see San Diego there. But all the institutions that you see there, there is only one thing that we consider as global collaboration is that we write grants together. We don't, an MOU does not serve as a collaboration for us. It's a statement to do something. Writing grants together with the teams in both places is what we call collaboration. Why? Greg will tell you in writing that J11, that's how we developed a whole team of new research investigators, because during the time, some of them have never seen even negotiation in budget. And Greg and I are talking about it, okay, this guy, and those are experiences that you can see in textbook. Where we are making choices, which framework to use and which one not to use and why we use them. All those discussions that you have in writing grant is actually the best training that is there. So let's next slide. So these are things that I wanted to make sure that as we leave, that I want you to know that there is available data from all of these studies that we have. We currently have 2 5-year studies, and we've had multiple 2 years and 1 years that are there. But all the data from these are available, and we are willing to be able to collaborate on using those data for publication. So if your interest is in looking on those to be able to build up publications to support a new grant, you will have those access to those grants. You just have to let Greg know, and then we have to process that we already developed to do that. The next thing is, if you wanted to develop new studies to tap into this framework or the infrastructure that we have to generate preliminary studies for new studies, again, that is an opportunity that is here. And of course, we do have support. If you wanted to visit and wanted to spend some time, maybe you are as an exchange program. Next slide. And I'm only putting this slide for you to understand. Next slide, Stanley. So if you can, one of the things that we're building newly here is a recognition that we're building a qualitative core in our team. And one of the things is here is that we do understand that studies that are happening in these places, that culture, the contents and lived experience are actually going to be very important. So we are putting a team that is led by Dr. Rono of a qualitative researchers in our team, and we want to be able to grow that so that they can actually help even when you're designing the studies to be able to put in those things. Even after you design your study and you get the award and you want to do them, they can actually help you with those lived experience and context refinement of your strategies. Next slide. So this is the opportunity I talked about. If you're able to come to Nigeria, we do have a guest house. So there are multiple hotels where we are in Enugu. There are 3 teaching hospitals in Enugu. There are multiple hospitals. There are about 6 universities in Enugu. So it is a very developed city that you can. We do have an office there. So we do have things to take you from the guest house to the office for you to stay during the time that we're there. So we are open to students coming. We are open to faculty members coming, early stage investigator coming for a period of time. We are also open to doing this and doing things like Fogati scholars programs that they actually support you to be able to go to a different country. There's so many opportunities for you to take a period to actually collaborate with an institution in low and middle income countries that is supported by MacArthur Foundation, by Fogarty Foundation, and so many other different agencies. But if you are interested in this, we are happy to collaborate to that and submit those applications together that allows you to come to Nigeria and spend 2 weeks, 1 month, 3 weeks, 3 months, or do an internship period. Next slide. So just in conclusion, to say that over the last decade, that the Nigerian Implementation Science Alliance and the Urban Research Institute have demonstrated that we can truly build something that is feasible, that is sustainable, that will provide those 3 things that we started with, have a very good dissemination forum, have a capacity building platform, and they have a research infrastructure that people can use. And we hope that you find a use to be able to connect to that. Next slide. I think that's my last slide. And this is just an acknowledgement of all the people, because over the years, we have not done this alone. And you can imagine all of this. And I want to say that all of this agency that you see here all started with support from the US government, either through USAID, God bless their soul, did a lot of good work in these countries, even though they are no longer there. We shouldn't forget how much good work they did. And to NIH, to CDC. So all of these organizations that are now local organizations in Nigeria, but they were all started and initially supported by US. I will give you an example. The Institute of Human Virology that you see there was started by University of Maryland. The APIN that you see there was started by Harvard. The CIHP that you see there was started by Columbia. So these were universities in the US that started these organizations together and then transitioned it to local distance. And we always remember them. In one of our meetings, we invited all of them back to thank them. But this is the last slide here, and thank you for having us speak at your meeting. Thank you.
Thank you so much. That was incredible, a great trio. And on top of everything, you finished 10 minutes before the end, which gives us time for questions, which is great. We can feel that you're several hours ahead of us because you have so much energy, and it's only 8 a.m. here and things are much slower. So that was a great way to get us started today. Thank you so much. I'll open the floor to questions. I'll start with one. Just to warm us up. I'll ask 2 in 1. I was very interested by the point you made about, oh, well, these training programs, have they led to other people being trained? And there were no other people being trained. Would you put that on the fact that there was no infrastructure to allow these people to train other people?
So one of the things that happens in people who write grants is that sustainment is an afterthought in most grants. So they start to think about sustainment on the last year of their grant. And if you're thinking about sustainment in your last year of your grant, you already failed because the resources you need to do those trainings are finished. They're gone. So, but what Greg and I decided to do from the first time we met, and he knew how that training was important for me. I was done my job. I was a tenured full professor in the US. I didn't have to go back to Nigeria. So when I was going there, I told him what my goal was. I wanted to mentor people. I wanted people to have the opportunity I didn't have when I was in Nigeria. That was the single driving goal for me. So mentoring was part of it. So whether some people wait for D43 to have training, and I told Greg, every grant we write that is 5 years, we must have training as part of his component. And he agreed to that. And that has been strong. So we thought about sustainment from planning. We thought about sustainment from the first writing, because the people that will sustain, you have to train them. You don't wait for the 5 years to do that. So a lot of the challenge is that people don't think about sustainment until towards the end of their grant, and they say, oh, who do we hand this over to? But there was nobody trained to hand over to. So, but if you had these 5 years, I don't think we're going to have a problem continuing the project that we're doing when our project ends in 5 years. People won't even notice that the project ended, because already we have built it into, and we have built it with all of those partners that I've told you. For example, the PhD that we're talking about is coming because of this grant, because all these partners have now agreed to host a PhD student in their organization as a resident implementation science. We didn't start that today. We started that for 10 years. So these are the reasons I think that fails, is that people don't think about it at the beginning, they think about it at the end.
Strong points there. Thank you. And my other question was, you mentioned the South-South collaborations. I wonder if you could tell us a little bit more about what you've started building with other institutions or individuals.
So if you remember the G11 grant I was talking about, that is the smallest grant, but the most impactful grant that we've had. So when you compare it to 30,000 to 2.5 million grant, you can understand why I say the 30,000 is a very impactful grant, because it was actually one thing that brought us in contact with UC San Diego and the wonderful team that I don't know how Greg found them, but he did inside UC San Diego. And this is your Office of Grant Management. They actually came to Nigeria, spent 2 weeks in Nigeria. I think some of them was the first time they see a light go off in the middle of their presentation, and then they turn on their laptop and it's dead and there's no place to charge it. And then, everything that can go wrong could go wrong. But they were so excited by what they can do in this place. So I can tell you that in the 3 years, they poured out their heart in trying to help develop that Office of Sponsor project, that even when the grant ended, they still came to Nigeria this year, even though the G11 is ended, and they're coming again next year. So that will tell you their interest in this. But something they did is also to expose us to other organizations like NCURA, the National Council of University Research Administration. This has been very important in building up the collaboration that we have. Now, what we are doing with them, we started this last year. We had a conference as part of the Nigerian Implementation Science Alliance to have a whole 3-hour discussion on grant management. And that UC San Diego initially was done with us, UC San Diego and NCURA. Last time there was 100 people. This time it was actually very big, that one of the NIH program officer that was there was so expressed by it that he went back and wrote a grant in NIH to say, I want to be able to have this thing become a kind of a national regional center for being able to do that. That is really the kind of thing that we look at. What we're hoping to do over the period of time is that we're not going to wait for the US government to give 30,000 to each of those universities to be able to build that. But now that we build one that we can use that experience, we want to be able to train people. So we're organizing a 12-month program where our Office of Sponsor Project is going to do a training every month. The same thing we do for the PIs, but this is now for the grant administrators. So they already finished that curriculum and then developed that and revised again, thanks to the UC San Diego team that have been really partners with us to be able to do that. So that starts off for the next 12 months. But what is also important is that they also helped 2 of our research administrators. One of them have already gone to the US and spent time at UC San Diego. The second one is already coming there I don't know where he's going to decide. He's actually on this call. So now they have 3 opportunities. You can go to South Africa, you go to Ghana, where NCURA has people there, or you also can come to the US. And if we're coming to the US, you'll be at UC San Diego. But again, that's our second person to be able to do that. Those teams, what we are hoping for, will now become the center to be able to train other institutions in Nigeria and in Africa about grant management. I think grant management is critical to the success of people who write grant. It may not be what you do, but you want to make sure you have a good grant management team, and we're grateful that we have that thanks to you, San Diego.
Thank you. I have more questions, but I'm gonna actually ask you the questions that have been coming up on the chat. Somebody said, hello, I have an HIV clinic in Boko venue sustained by CO5C3. We solve staff turnover with performance-based incentive pay, resulting in full staffing and no turnover for first time at this hospital. And they wanted your contact info to start expanding cervical cancer screening. So I guess this shows that there is engagement from people who are out there.
That is good. Victor, remember, I like Boko. Boko is one place that Greg will remember. One of our studies, we talked about 80 sites. We worked in 80 sites in Benue State, and that includes Boko. Beautiful people. You'll like them.
And then somebody was asking, go for it, sorry. Oh, I heard a voice. Okay. Feel free to interrupt if you're able to talk. There was another question asking how the cervical screening is performed.
So the cervical screening, so there are two opportunities to do cervical cancer screening. And one of them is, of course, the VIA, what we call the visual inspection, where they do a visual inspection, they put acetic acid, and they look at abdominal areas. It has an advantage in a resource-limited area. One of the things is that if you see an abnormal area in what we call cancer insidum, that they actually do a thermal ablation as treatment. So you can visualize, you can treat at the same time. The other one is to do a HPV testing. Of course, that is the standard WHO gives you. That is what they want everybody to go to. But I can tell you, first of all, you have to get the machines in all of those places. You have to get all of those things in there. And after you have the HPV, the idea is that the people who are now HPV positive, you can now do the VIA. So that way you still have to do the VIA if you're going to treat. One of the challenges that we have seen, and I don't know if Stanley mentioned there, is actually in referral completion. So when you get those people with HPV, and we actually have a group that is working in Botswana, and one of the things they find out, they were having problem from the other side. Their own was they were doing comb biopsies on those abnormal things. And when the patient come in, they do a comb biopsy, they have an abnormal result, they can't even get it back to the patient because there's no network to get it back to the patient. So they have this sample of cancer and they're holding it and they can't find the patient that have the sample. That is that. And then from the other part, you have somebody that abnormal thing, you send them. And then they're waiting for when they get enough money to go to the hospital where you refer them. So this referral completion is one of the things that we're actually focusing on how to resolve. But we have started to put things in place now. They are using technology in terms of smart card, using what we call navigator system to be able to do that. But there is still an advantage to being able to to visualize and treat on spot those cancers that are early in stage. So we have both strategies as what is happening in Nigeria. Our study was looking at the VIA and how it does. There's another group in Nigeria that's looking at the HPV testing and how self-sampling, on how self-sampling is used to collect sample for HPV. But also they are falling into some of these challenges I'm telling about. So they do the self-sampling, they send it to you, you got the positive, how do you get it back? So this is now where you have a zip code and you can send the driver to the house because it has a house address. Some of those addresses are, if you go about half a mile, you see a mango tree, they make a right. And if you make a right, you see about 5 houses there, is the third house in the place there that you go to. One of the things our smart card has actually done is that when you have the smart card, it's built a GIS in it. So that when they go home, scan it, actually can tell you exactly, it can take you to the person's house. Because of the GIS that's built into those cards, and the patients actually all have it when they have that. So we're trying new things to see how to be able to resolve that so that by the time we finally move from VIA to HPV testing alone, we can actually see how to not hold people's results in our hands while they're dying because we can't reach them.
Well, unfortunately, we're at time. I would have loved to hear more about implementation science framework adaptations to the Nigerian context and other contexts, but we'll have to invite you again. Thank you so much for sharing all your fantastic work with us today and for the time to present. I know it's later in Nigeria, and also thank you so much, Dr. Aarons, for making this happen. And
Thank
thanks
you, everyone.
everybody for joining.
Thank you for having us. Thank you.